Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicos. Today I am going to discuss about the carcinoma of rectum. It is the most common type of malignant tumor found in women. Origin: the carcinoma commences as a nodule of atypical columnar epithelium. Its rapidly proliferating cells extend on the surface by exuberant growth at its edges. Similar changes occur on the deep surface, that is submucosal, of the nodule. The lesser malignant types continues to extend towards the lumen. The more malignant type soon become necrotic at the center and give place to an ulcer with indurated, everted edges. Operational specimens show that in some part of the bowel that has been removed in addition to the carcinoma. There are one or more adenomas or papillomas, proof indeed that adenoma and papilloma of the rectum are pre-carcinomatous conditions. In some of the cases, there is more than one carcinoma present. Types: there are three types recognized: adenocarcinoma, colloid carcinoma, and anaplastic carcinoma. Local spread occurs circumferentially, rarely extends more than 2 centimeters up and down the rectum. It takes 2 years for complete encirclement. The annular type is common at the rectosigmoid junction after the muscular coat is penetrated. The growth spreads into the underlying fat but still is limited by the fascia propria, that is perirectal fascia. Eventually the fascia propria is penetrated. If penetration occurs anteriorly, the prostate, seminal vesicles or bladder is involved in the male. In female, the vagina or the uterus are involved. In either sex, if the penetration is lateral, a ureter may be implicated. Posterior penetration involves the sacrum and the sacral plexus. Lymphatic spread. The lymphatic spread from the carcinoma of rectum above the peritoneal reflection occurs exclusively in upward direction. Below that level to within 2 centimeters from the anal orifice, the lymphatic spread is still upward. But the first step is in pararectal lymph nodes of Girota. Downward spread is exceptional. Drainage along the subcutaneous lymphatics to the groin is confined for practical purposes to the lymph nodes draining the perianal rosette and the epithelium lining the distal 2 centimeters of the anal canal. Only late in the disease metastasis at higher level than main trunk of superior rectal artery. The radical operation should ensure that the highly lying lymph nodes are removed by ligating the inferior mesenteric artery and vein at the highest possible level. Venous spread. Spread via the venous system occurs late, except in that portion of the anal canal where the anodem is firmly adherent to the deeper structures. Anaplastic and rapid growing tumor in younger patients are more liable to spread in this way. The principal site for blood-borne metastasis are liver, lungs, adrenals, etc. Peritoneal dissemination may follow the penetration of perineal coat by a highly lying rectal carcinoma. Stages of progression. Carcinoma of the rectum does not metastasize early. Duke's classification of carcinoma of rectum, it is classified into 3 stages. The growth is limited to the rectal wall. The growth is extended to the extrarectal tissues, but no metastasis to the regional lymph nodes. There are secondary deposits in the regional lymph nodes. These are subdivided into where the pararectal lymph nodes alone are involved. Secondly, where the nodes accompanying the supplying blood vessels are implicated. Histological grading. In majority of the cases, carcinoma of the rectum is a columnar cell adenocarcinoma. The more nearly the tumor cells approach normal shape and arrangement, the less malignant is the tumor. Conversely, greater percentage of cells of an embryonic or undifferentiated type, the more malignant is the tumor. Broader's histological classification. It is classified into 4 types, simplified by Dukes into 3 grades. Low grade, well differentiated tumor. Second, average grade. Third, high grade anaplastic tumors. Colloidal carcinoma. It is present in few patients. There are 2 forms, primary and secondary. More frequent is the secondary mucoid degeneration of adenocarcinoma. Histologically, the glandular arrangement is preserved and mucus fills the acini. This type is of average malignancy. In few cases, the tumor is a primary mucoid carcinoma. The mucus lies within the cells, displacing the nucleus to the periphery. Primary mucoid carcinoma gives rise to a rapidly growing bulky growth which metastasizes very early and the prognosis of which is very bad. Clinical features. Carcinoma of the rectum is common in early life also when commences in youth. In spite of radical treatment, death usually results within an year. Usually the early symptoms are so slight that the patient does not seek advice for 6 months or so. Bleeding is the earliest and constant symptom. There is no characteristic about the time at which it occurs. Neither is the color nor amount of blood distinctive. Usually the bleeding is slight in amount and occurs at the end of the defecation or is noticed because it has stained underclothing. The bleeding is in every respect simulates that of internal hemorrhoids, and it is lamentable that in spite of repeated exhortation, the patient's doctor sometimes fails to examine the rectum and prescribes a salve white to growth while the growth advances to inoperability. Sense of defecation. The patient has his bowels open but feels that there is more feces to be passed. This is a very important early symptom and is almost invariably present in tumors of the lower half of the rectum. The patient may endeavor to empty the rectum several times a day, called spurious diarrhea, often with a passage of flatus and a little blood-stained mucus, that is blood slime. Alteration in bowel habit. Increasing constipation is the commonest deviation from the normal bowel habit. Taking aperient becomes necessary and it may cause diarrhea. A patient who has to get up before accustomed hour in order to defecate and one who passes blood and mucus in addition to feces is usually found to be suffering from carcinoma of the rectum. The patient with annular carcinoma at pelvirectal junction must be having increasing constipation and cauliflower growth in the ampulla of the rectum with early morning diarrhea. Pain occurs late in the disease, colicky in nature and due to some degree of intestinal obstruction. In case of advanced growths of rectosigmoid, when a deep carcinomatous ulcer of the rectum erodes the prostate or bladder, there is severe pain. Pain in the back or sciatica occurs when the growth invades the sacral plexus. Weight loss is suggestive of hepatic metastasis. Abdominal examination. In early cases, nothing is found. When the advanced annular growth is situated at the rectosigmoid junction, signs of obstruction to the large intestine are likely to be present. By the time the patient seeks advice, metastasis in the liver may be palpable. When the peritoneum is studded with secondary deposits, ascites results. Rectal examination. In early cases, digitally palpable as a plateau or a nodule with a indurated base. When the center ulcerates, a shallow depression will be felt, the degree of which are raised and everted. This combined with the induration of the base of the ulcer is a frequent and unmistakable finding. On bimanual examination, it may be possible to feel the lower extremity of a carcinoma situated in the rectosigmoid junction. Finger withdrawn may show smeared with blood or mucopurulent material, tinged with blood. If the growth have lymph nodes and in the lower third of the rectum felt as one or more hard oval swellings in the extrarectal tissues posteriorly or posterolaterally above the tumor. In females, a vaginal examination should be performed and when the neoplasm is situated on the anterior wall of the rectum with one finger in the vagina and another in the rectum, very accurate palpation can be carried out. Proctoscopy. In complete knee-elbow position, carcinoma is seen if present. In case of doubt, sigmoidoscopy is to be done. Biopsy. Employing biopsy forceps by way of proctoscopy, a portion of the edge of the tumor is removed. If possible, another specimen from the more central part of the growth is obtained. Except histological examination will enable expert histological examination will enable diagnosis of carcinoma to be confirmed, but the tumor can be graded as to its relative malignancy. Barium enema. It is required when sigmoidoscopy is unsatisfactory due to spasm in the suspected carcinoma of pelvirectal junction when sigmoidoscopy fails to reveal the growth due to spasm of the bowel below it, and when multiple adenomatous polyposis of colon must be excluded. When a seemingly benign papilloma or adenoma shows evidence of induration of friability, it is certain that malignancy has occurred even in spite of opposite biopsy findings. On the other hand, biopsy is invaluable in distinguishing carcinoma from an inflammatory stricture or an amoebic granuloma, which simulates a carcinoma very closely. A possibility of a neoplasm being an endometrioma should always be entertained in patients with dysmenorrhea. Finally, the importance of bearing in mind the possibility of a carcinoid tumor in atypical cases has already been emphasized. In the last four instances, biopsy will frequently establish the correct diagnosis. Treatment. Some form of excision of rectum is mandatory, if at all possible, because of extreme suffering entailed. If the neoplasm remains, apart from coexistent disease or senile enfeeblement, the only prohibition to excision of the rectum are widespread distant metastasis and extensive perineal deposits. Many instances have been reported where a presumed solitary metastasis in the liver has been resected either at the time of excision of the rectum. Even when the metastasis in the liver is irremovable, a resection of the rectum is often justifiable and the patient may survive in comfort for 1 year or two. A combined abdominal and peritoneal excision offers the best prospect of eradicating the disease. This operation can be carried out as an abdominal perineal procedure. Means the abdominal part of the operation is undertaken first, or a perenio-abdominal, where the perineal stage is performed before the abdominal stage, or as a synchronized procedure where two operations are performed simultaneously. Preoperative procedure. 5 days preoperative sterilization of the alimentary tract by sulfafuxidine is required. The colon is cleaned by enema or colon wash as necessary. Blood and electrolyte deficiencies are corrected. An indwelling catheter is inserted into the bladder before commencing the operation. Combined synchronized excision of the rectum. The patient is laid in Trendelenburg lithotomy position. The legs are supported in special crutches designed by Lloyd Davis. Access is afforded to the abdomen and perineum at the same time. The surgeon operates at the same time, one performing the perineal dissection and the other abdominal portion of the operation. This considerably reduces the time and obviates turning the patient. The resectability rate increases by this operation. Abdominal. The abdominal surgeon makes a left paramedian incision, extending it well above the umbilicus. The liver and peritoneum are examined for metastasis and the degree of flexibility of growth is established. The small intestine is packed away from the pelvis. A self-retaining retractor is placed in the wound and the pelvic colon freed by dividing the congenital adhesions on the left side. The peritoneum and the pelvic floor are divided with a knife by an incision which runs from the colon at the proposed site of division over the mesocolon and across the base of the bladder or near the cervix on the peritoneal floor and then upward on the right side of the mesocolon. The peritoneum is now raised using the points of scissors to expose the ureters and testicular or ovarian artery. The mesocolon is now divided at the site of the proposed division on the colon and the trunk of the inferior mesenteric artery, ligated and divided distal to the first branch. Some surgeons prefer flash ligation of the artery at its origin from the aorta. The rectosigmoid mesentery is further divided and separated from the sacrum by blunt dissection with the finger. In this way, the sacrum is cleared down to the coccyx. The peritoneal incision anterior to the rectum is now deepened, and the seminal vesicles or the vaginal wall is identified so that the fascia behind them is cleared by a dissection leading to the prostate or perineal body. The middle rectal vessels, usually lying anterior to the lateral ligament on each side, are now seized with the clamps divided and ligated. The site of division of the pelvic colon is cleared of fat, and colon divided between the clamps with the diathermy. By this time, the perineal surgeon working from below has mobilized the anus and the lower rectum so that the whole of the bowel below, together with a clamp, can be passed through the perineal wound by the abdominal surgeon. Hemostasis over the sacrum may be difficult, but is achieved by diathermy and a hot saline pack left in position for a few minutes. The pelvic peritoneum is now united by continuous catgut stitches from the bladder right back over the promontory of sacrum. The site in the RIF for the colostomy is then selected. This should be equidistant from the umbilicus and the left anterior superior leg spine, and is usually sited at the linea semilunaris, about 1 inch above the spino-umbilical line. The circular piece of skin and fasces the size of a penny is incised, and this hole deepened to excise similar layers of fascia and peritoneum. The protected end of the colon with the clamp is now passed through this incision, and colostomy performed by suturing the colon to the peritoneum and mucosa directly to the skin. If the paracolic gutter is narrow, it is encircled with a running suture. This is tied when the colon has been passed through colostomy incision. This will close the lateral space. The abdomen is closed and the layers of the incision protected from the colostomy. The adherent plastic colostomy bag is then fitted in position, and the dressings are placed on the abdominal wound. Perineal surgeon. When the abdominal surgeon has made certain that the condition is operable, the perineal surgeon closes the anus with the persisting sutures of the stout silk. An elliptical incision between the tip of the coccyx and the central perineal point is made around the anus and deepened. The left forefinger is insinuated into the levator ani, which is divided lateral to the finger, first on one side and then on the other. The dissection is deepened posteriorly by incising Waldes fascia, which is a thick condensation of pelvic fascia lying between the rectum and sacrum. Contact is made with the abdominal surgeon. The apex of the skin anterior to the anus is grasped in a hemostat which serves as a retractor, and by scissors and gauze dissection the wound is deepened. When the catheter is within the membranous urethra will be felt. Both in male and female, a plane of cleavage will be found between the rectum and the prostate or the vagina posteriorly. This plane being carefully determined, the strong median raphe of the perineum is divided, after which the rectum can be stripped from the prostate or vagina. The posterior wall of the vagina is frequently taken with the rectum. When the abdominal surgeon has cleared the rectum laterally, whole of the anus and the rectum can be drawn downwards and removed. Hemostasis must be secured and the perineal wound closed anteriorly and posteriorly in layers around the large drainage tube. Large dressings of gauze and wool are applied over the area, and a triangular bandage is used to keep the dressing in place. After treatment, the patient is returned to bed, blood transfusion continued as necessary. This catheter is connected to a closed catheter drainage system and left for 5 days. After removal, if voluntary micturition is not established, catheter may be reinserted. Carbachol may be necessary to establish this. Reactionary hemorrhage from the perineal wound may demand a return to the theatre to open the pack and pack the wound with gauze. The color of the colostomy must be watched to make sure the blood supply is adequate. Small bowel obstruction may occur by herniation in the lateral space of the colostomy or through the pelvic peritoneal closure line. Discharge of urine from the perineal wound demands immediate investigation for bladder and ureteric damage. Less extensive operations, abdominal radical restorative resection or anterior resection. In case of carcinoma of the rectum situated above the perineal resection, lymphatic spread is virtually confined to the upward paths, and wide resection of the bowel with its lymphatic fields, followed by end-to-end anastomosis and preservation of the sphincter mechanism of both justifiable and highly desirable. This procedure is unpopular these days due to the recurrence as for the most part to local implantation of pre-malignant cells into the distal segment that is to be preserved. The cervical and the routing of these cells being favored by disinfection of the intestine by sulfosuccinate and antibiotics. Naunton Morgan has shown that when a suitable clamp is placed at least 2 inches below the neoplasm and the rectum is irrigated with buffered Atkins solution, chlorinated soda of 0.5% available chlorine, the lumen of the proximal end and edges of both segments are swabbed with the same solution before anastomosis. The incidence of local recurrence is reduced considerably. Restorative resection should be performed only when the tumor is high in the rectum, at least 4 inches above the anal orifice, and even then it should not be attempted if the build of the patient and anatomy of the colon and its vascular supply makes restoration of the continuity of the alimentary canal difficult, nor in the younger subject in whom these neoplasms grow rapidly and recur. The perineal operation. In this operation, lymphatic field in relation to the inferior mesenteric artery are not removed and is reserved mainly as a palliative for poor risk patients when the neoplasm is situated in the lower third of the rectum. Hartmann's operation. For an old and feeble patient who would not stand an abdominoperineal procedure, it is an excellent procedure. Through an abdominal incision, the rectum is excised down to within 1 inch of the anus. A colostomy performed and the peritoneum is oversewn to cover the pelvic defect in the usual way. The cavity below can be drained through the anus, which is divided posteriorly. In the old patients where the neoplasm is usually slow growing and spread is late, this is the most suitable operation. Palliative colostomy. When there is intestinal obstruction or where there is infection of the neoplasm, it is indicated. It is often possible to resect the growth later. More extensive operations. When the carcinoma of the rectum has spread to contiguous organs, the radical operation can be extended to remove these structures. For example, in males where the spread is usually to the bladder, a total cystectomy and resection of the rectum can be effected. In the female, the spread may be to the uterus and a total hysterectomy should be undertaken in addition to excision of the rectum. If a bladder is involved, the pelvic evisceration must include that structures. Pelvic evisceration for carcinoma of the rectum is justifiable only when the surgeon is reasonably confident that the growth can be removed in toto. When the growth is of a high malignancy, the likelihood of local recurrence is so great that pelvic evisceration is contraindicated. Pelvic evisceration. Brunstein's operation. The aim of the operation is to remove all the pelvic organs together with the internal iliac and obstructor group of lymph nodes. The lithotomy Trendelenburg position facilitates the procedure and ligation of both internal iliac arteries diminishes the blood loss. Rarely, as it is possible to preserve sufficient peritoneum to form a pelvic peritoneal floor, and the small intestine fills the empty pelvis. Special care must be taken to suture accurately the perineal skin and to avoid pressure necrosis of perineal incision by nursing the patient on alternate sides. Some form of urinary diversion is necessary. Carcinoid tumor. Though it is categorized as a malignant tumor according to its lethal properties, is looked upon as a gradation between benign tumor and carcinoma. Now it is rare, and when atypical neoplasm of the rectum is encountered like benign lymphoma, carcinoid tumor originates in the submucosa. The mucous membrane over it is intact, so it is seldom produces evidence of its presence in the early stages when it appears as a small plaque-like elevation. The incidence of clinical malignancy like metastasis is about 10%. Multiple primary carcinoid tumors of the rectum are not infrequent. It is slow in progression and usually metastasis late. Treatment. If the growth is more than 1 inch in diameter, if recurrence follows local excision, or if the growth is fixed to perirectal tissues, a resection of the rectum is advisable. Even if there is metastasis in the liver, resection may prolong life. That's all about the malignant tumors of the rectum, and in the next video I will discuss about some other disease. Thank you.